Hello, everyone. I'm Melissa Budzinski, and I'm with Gilda's Club Grand Rapids, and we're so glad that you're joining us today on Facebook Live. If you are listening or you have questions, we would love to hear from you. Just give us a little post below and let us know you're there, and post any questions you have. We're so happy to have with us today Dr. Abdullah from the Cardiac Oncology Clinic at Spectrum Health. And the focus there is the specialty on heart health before, during, and after treatment. Is that correct, Dr. Abdullah?
That is correct.
Great. So he's going to speak with us today about what they do there, give us some great information about cardiac health and oncology and treatment. We're so grateful, Dr. Abdullah, for you to be with us today. This is very, very important information to bring to our membership and to the public, and we're just really grateful for you spending some time with us today.
Oh, thank you so much for having me. It's an honor to talk to all of you today and really highlight what this program is all about. Absolutely.
Great. So again, I want to encourage you, if you have questions, go ahead and put them right in the comment area on this post, and Dr. Abdullah will try to get to all of them after he's done with his presentation. So with that, I think we'll get started, and you were going to share your screen now. So it's
Yes.
going to take a little second here. Give us some grace there we go. And then
I'll minimize this and hopefully you can see my screen.
I can see yours. Yep. Oh, perfect. Great.
All right, perfect. Well, again, thank you all for joining us and thank you for giving me the opportunity to talk to you. I want to talk to you about our cardio-oncology program, which really is focusing on optimizing the heart health of cancer patients. Now, the good news is that cancer survivorship is continuing to improve. This is just a graph showing you since the 70s into the early 2000s that the relative survival of cancer patients over a 5-year period has been steadily increasing, and it's over 70% in the last decade. So very, very encouraging news. And as a consequence of this, we are now seeing patients that are cancer survivors that are living longer, and as a consequence, unfortunately, sometimes we end up experiencing cardiac complications that may happen several years down the road after exposure to cancer treatments. And one of the things that is worth highlighting is that if patients do not die of their cancer, the second reason they do die is actually heart disease. This is a graph showing you that over 10-year time span, looking at various types of cancers, whether breast, melanoma, skin, prostate, endometrial, urinary, or all of the sites combined, there is an increase in the incidence of death from heart disease in cancer survivors. So really a growing patient population that do experience cardiac complications down the road, several years down the road. And one thing really worth highlighting are the childhood cancer survivors and the risk for various cardiac complications. And we feel that this is really an underserved patient population, meaning cancer patients that were treated during childhood or early adolescence or even in their early 20s, and now they're in their 40s and 50s, and they were exposed to potentially cardiotoxic chemotherapy agents. The most common one we think about is a medicine called anthracycline-based chemotherapy, like adriamycin or doxorubicin, what is commonly used. In addition to radiation to the chest area, these do put patients at a higher risk for various cardiac complications. So this graph is showing you the incidence of over a 10-year period and 15-year period in the cancer survivors to experience any cardiac event. So the general population has an incidence of only 0.7% of any cardiac event in 10 years, 1.3% over 15 years, while a cancer survivor, childhood cancer survivor, still low, fortunately 2.3%, but definitely much higher than the general population. If you look at heart failure, general population has an incidence of only 0.1% of heart failure, while cancer survivors, again, fortunately, it's only 1%, but technically it's 10 times more than the general population. So generally, survivors of childhood cancers have at least a 3 times higher incidence of various cardiac complications. And that's why we should definitely be in tune to this special patient population in their later in life, midlife, and even later for potential complications that could be affecting their heart as a relation to prior chemotherapy or radiation to the chest they may have received. Now, what is cardio-oncology? So by definition, it's cardio, heart, and oncology, cancer. So by definition, it's a combination of two fields. And if you think about this, there are risk factors that cause or increase the likelihood to develop cancer, and also risk factors that cause or increase the likelihood to develop heart disease, cardiovascular disease. And there's a lot of overlap in these risk factors. So older patients, tobacco abuse, diabetes, obesity, high blood pressure, high cholesterol, sedentary lifestyle, certain infections, inflammatory conditions, anything that kind of puts stress on the body has been implicated to cause both cancer and heart disease. And so that's why when patients have cancer, they most likely also have risk factors that are associated with causing heart disease if they don't already have heart disease. And so it's really the combination of these two conditions that puts these patients at a higher risk for various complications. Now, there's been a lot of data recently. This is relatively a new field in medicine, kind of combining the cardiac care of cancer patients. Historically, you have the cancer specialist working in their own area and the heart doctor working in their own area, and they rarely talk to one another, and they only talk to one another when they needed one another. Meaning, if the cancer patient ends up with some major cardiac complication, then they go to the heart doctor. But now when we're recognizing that we can do things up front to reduce the likelihood for cardiac complications from certain cancer treatments. This one study from a few years ago looked at various kinds of chemotherapy and risk factors, and they gave points to these risk factors. So if patients are going to get an anthracycline-based chemotherapy or any other kind of chemotherapy, they would get 2 points. So this is just like a scale that they came up with. And we don't need to go into all the how they derived all this, but any kind of chemotherapy, basically patients would get 2 points for that. And depending on how old they are, if they are 75 to 79, they get a point. If they're 80 to 94, they get 2 points. And then if they have any of these things, so if they have coronary disease, they get 2 points. If they have an irregular rhythm problem, atrial fibrillation or flutter, they also get 2 points. If they have diabetes, 1 point, hypertension, 1 point, and renal failure, 2 points. And then they counted the points for these patients who have these conditions or risk factors. And they found, for example, like if patients have only 0 to 3 points, their incidence for heart failure or cardiomyopathy, which is a weakness to the heart muscle, over a 3-year period is low, but it's not insignificant. 15% of these patients. The risk is definitely higher as the risk factors or those points become higher. So you could imagine, so medium risk, I mean, we're talking a 25% incidence. 1 in 4 patients are going to have a cardiac complication over 3 years if they have 4 points or more. And if we go back to this, it's not that hard to get 4 points. If you're getting chemo, that's 2 points already. If you have diabetes and hypertension, 1 + 1 + 2, 4 points. That's already 4 points right there. If you're older, you're at 5 points. And if you have other risk factors, you could easily be at 6 points. And then the incidence is up to 40%. So this is not a small patient population. It's definitely a very large patient population of the cancer patients that are at risk for various cardiac complications. This is another study that looked at the risk factors that increase the likelihood of complications. So we're following cancer patients who have diabetes or not, who have hypertension or don't, who have coronary disease or don't, and those who have risk factors. So if they have diabetes, they have 1 point, 1 risk factor. If they have diabetes and hypertension, that's 2 points. If they have diabetes, hypertension, and tobacco abuse, for example, that's 3 points. And you could see in all those cancer patients that had diabetes, high blood pressure, or known heart disease, or had 2 or more risk factors, the incidence of cardiac events over a 7-year period followed here is quite high. So a diabetic patient who's a cancer patient has a 30% incidence of developing cardiac complications over a 7-year period. Same for a patient with just hypertension, heart disease up to 40%. And if patients have diabetes, high blood pressure, high cholesterol, and they're cancer patients, we're talking about a 50% incidence here of a cardiac complication over a 7-year period. So really just trying to highlight that this is a large problem and a large patient population that are at risk for cardiac complications. And that could include a lot of different things, and I'll go into some of that. Now, chest radiation as well. Sometimes we don't really think about this too much, but the reason radiation to the chest works is because you are blasting the chest basically with high energy beams that are supposed to kill rapidly dividing cancer cells. And so, but they don't kill just cancer cells, they kill everything in their way, or not everything, but they do have an impact on other organs that are in their way. And so the heart is right there, right in the middle of the chest. And so those patients are at a higher risk to develop heart disease at a premature age, develop valve disease at a premature age. There is also a lining around the heart called the pericardium that can thicken, and that can cause something called constriction, and that can cause heart failure. So chest radiation can certainly have long-term cardiac effects. More recently, the radiation oncology doctors are trying more to focus the beams so as not to have beams that scatter and affect the heart, but still the heart does get exposed. And these techniques only started happening in the last 10, 15 years at most. And so patients who had radiation to the chest over 10 years ago, they did not have that more targeted therapy just because the technology did not allow it back then. And so they definitely would have received more radiation than, let's say, someone who would be treated now, where we are able to shield the heart a little bit more. And this is data showing you the incidence of what we call major adverse cardiac events. So dying from a heart attack or heart failure, hospitalization, or having heart failure episodes. And so if we look at those patients who do not have any pre-existing heart disease in this blue line, the incidence for a cardiac event followed over 5 years is still low. It's less than 5%. But those who have pre-existing heart disease, you could see that the incidence with radiation exposure is much higher, up to 20% here over a 5-year period. So meaning those patients who have heart disease and those that end up getting radiation to the chest area have up to a 20% incidence of developing a cardiac event within 5 years. This study also looked at the dose of radiation. So if they got a low dose or a high dose, it didn't seem to make that big of a difference if they did not have any pre-existing heart disease. Now, if they did have pre-existing heart disease, it also did not matter the dose. The risk for cardiac events was still high, whether they received low or high radiation. Now, cancer therapies, again, there's a lot of very, very, very powerful, very effective cancer treatments out there that are only getting better every day. And there's a lot of new cancer treatments that are continuously being introduced on the market. And a lot of them are targeted, but as we learn more and more about these therapies, a lot of them also end up having various side effects that affect the cardiovascular system. The ones that have been historically implicated in causing heart failure are the anthracyclines that I mentioned earlier, like adriamycin or doxorubicin. Some patients may recognize it as the red devil, it's been called, highly effective, but unfortunately can sometimes increase the likelihood for cardiac complications, specifically heart failure. There are the HER2 blocking agents called Herceptin or Perjeta. Some patients with breast cancers would be on if they are HER2 positive. Those drugs can increase the likelihood also of heart failure. There's a new class of medications called immune checkpoint inhibitors that are used on various kinds of cancers right now that have also been implicated in heart failure, as well as inflammation of the heart or myocarditis. Other agents called what we call VEGF inhibitors, like sunitinib or sorafenib, used, for example, in some kidney tumors or other kinds of tumors, can cause significant high blood pressure. 30 to 50% of these patients on these drugs have significant high blood pressure that can be challenging to control. Other things, there's irregular rhythm problems that can develop. One of them is called ibrutinib, used in patients who have CML, that has about an 11% incidence of causing atrial fibrillation. Valvular heart disease, we talked about radiation, and so a whole slew of different agents that are constantly being introduced on the market. And as we use these drugs more and more, we end up finding that they do have some cardiac side effects. Now, what are some of these cardiac side effects? Can be something as chest pain, could be shortness of breath, could be swelling as a sign of congestive heart failure. Some agents can cause a spasm or narrowing to the heart arteries. That can cause heart attacks, that can cause silent heart attacks. Various medicines can cause rhythm problems like atrial fibrillation or other rhythm abnormalities. We talked about radiation affecting the valves. Or premature heart disease, coronary artery disease. Some blood pressure, some cancer agents can cause high blood pressure, others can cause low blood pressure. Some can cause inflammation of the heart muscle or myocarditis. Others cause inflammation of the pericardium, which is that lining around the heart. Some can cause fluid buildup there. Others can cause pulmonary hypertension. And so in the cardio-oncology program, we have three goals. Number one, prevention. And there is now data showing us that if we optimize patients' cardiovascular status, meaning if we get their blood pressure under control, diabetes under control, high blood pressure under control, smoking cessation, quitting smoking, healthy exercise patterns, and dietary modifications, that we can reduce the likelihood for potential cardiac complications down the road. So there are things we can do to reduce the likelihood that the heart would be affected during cancer treatment. That's the prevention piece. There's also treatment. So during cancer treatment, we are monitoring patients for signs of early cardiac damage. And we do that with echocardiograms or ultrasounds of the heart to evaluate heart function. And also, if patients were to develop any changes in their heart function during treatment, or if they were to develop any cardiac symptom, then we certainly are available to treat that, with the hope always to treat patients and try to stabilize them so that we do not have to interrupt their cancer treatment. And then thirdly, long-term surveillance. So that is focusing on the cancer survivors who don't necessarily have any cardiac problems right now, but they've been exposed to certain treatments that over years, the next 5 to 10 years, would put them at a high risk category to develop cardiac complications. And so we want to find those patients so that we follow them early on to identify early signs before it gets too late. And we do serial imaging depending on the condition as well. And so really stages of reevaluation. Number one, to risk stratify patients, detect any injury early on, to try to identify whom we could help the most, and detect injury in the survivors as well. And again, we talked about the various conditions, whether cardiomyopathy, decline in heart function, pericardial disease, premature coronary disease, pulmonary hypertension, or vascular problems as well. And we use various imaging modalities like echoes or CAT scans of the heart or MRIs of the heart as well. And some of the imaging that we do, so this here on the left-hand side is just showing you an echo ultrasound pictures of the heart, where we are able to evaluate heart function, looking for abnormalities in the heart's pumping capacity. And sometimes we might do an MRI of the heart. That is considered the gold standard or the best way to evaluate heart function, where we get beautiful, perfect pictures of the heart to look at heart function and look for fibrosis, or looking for signs of, like, let's say patients have inflammation of the heart, myocarditis. This would be the the one and only modality really to image the heart to look for myocarditis, or let's say we want to look for prior heart attacks. This would be also an ideal imaging modality for that as well. So the cardio-oncology program at Spectrum Health, our mission is really to prevent today's cancer patients from becoming tomorrow's heart patients. We do serve as a bridge between cardiology and oncology, and we do provide expertise on the various cardiac side effects of many cancer therapies that are continuously being introduced onto the market. And we work closely with all the cancer specialists to tailor the best surveillance for cancer patients and the best treatment if they do have any cardiac complications. And really, the goal is not just to treat the cancer, but to treat the patient as a whole. And just recognizing that whatever treatment patients are exposed to for their cancer treatment, recognizing that it might have impact on other organs. We are always, our medical oncology colleagues are also working tirelessly for the goal of curing the patients, but we want to cure their cancer, but we don't want them to become a heart patient down the road. So if there's anything we can do up front or monitor them closely to find a problem early on before it's too late, that's what we want to do, is to really treat the patient as a whole and not just focusing on the cancer. And then we have general guidelines in terms of which patients to see, but really any cancer patient that might have any cardiac symptoms or cardiac risk factors that have been exposed to certain treatments, we're more than happy to see these patients. Generally, we say if they have abnormal EKGs, abnormal echoes, risk factors, monitoring, symptoms, any preoperative evaluation, and survivors as well. And that's all I had. This is our team, myself. We also have my colleagues, Dr. Laura Franey, and we also have a physician assistant, Megan Weller, and our nursing team as well. That's all I have. So happy to take any questions.
Oh, great. Thank you so much. If you want to stop sharing, there you go. Yeah. And we can, I think, see. That was very, very interesting and enlightening. There's many things I didn't know at all about cardio-oncology, and am glad now, to have heard you speak.
Thank you.
Many of our members have questions or talk quite a bit about their cardiac situation in reference either prior to their treatment or after their treatment. And so this clinic is, we feel very, very important in the Grand Rapids area, and just really grateful that we have it. I do have a couple of questions.
Mm-hmm. Absolutely.
That's okay. So just wondered how someone would weigh the benefits or the risks of their cancer treatment in relation to this possible heart or cardiac effect.
Yeah, that's a great question. And, obviously everything we do has risks and benefits. And so we're always trying to find that balance. On the one hand, you want to treat the cancer as effectively as possible, but at the same time, you don't want to do something that is going to end up detrimental to the patient's health, especially their heart health.
Yeah.
And so we're always trying to assess each patient, because every patient is very unique. Each patient is going to have a certain kind of a cancer. They're all going to have a certain stage of a cancer. They're all going to get exposed to different kinds of agents. And on top of that, each patient is unique in that they have either heart disease, or they have risk factors for heart disease, or they might not have any risk factors. So all these things have to be weighed into that decision. So for example, we might have a 50-year-old woman who has otherwise been perfectly healthy her whole life, and then unfortunately develops, stage 2 breast cancer. And the oncologist is recommending adriamycin treatment. Well, that patient is going to be pretty low risk for heart complications. And so in that scenario, it's really not that much debatable in terms of what to do. Yes, absolutely. The risk of taking adriamycin, the benefit of that is very high to prevent any recurrence. And the risk for that affecting the heart is low. It's probably, less than 5%. So in that scenario, it's absolutely the oncologist's recommendation, which is completely appropriate to proceed with something like that, with that form of treatment. Now you add on top of that, let's say it's left-sided breast cancer, and then they're also going to get radiation to the left side. So they got adriamycin, but now they're also going to get left-sided radiation. Well, fortunately now the radiation oncologists, again, they're better in shielding the heart, but the heart still gets some scatter.
Mhm.
So in these scenarios, again, it's still not prohibitive. Absolutely, that will still be the best treatment for the patient, to get the adriamycin plus the left-sided radiation. But because they're getting left-sided radiation in the cardio-oncology clinic, now we're going to monitor them closely.
Mhm.
And there are guidelines for how frequently to image their heart, to identify any early signs, and to evaluate them clinically for any early signs, so that, again, it's not too late to have to deal with a problem if it were to develop. And again, it's not that it's going to develop, they're just statistically at a higher risk patient population.
Okay.
Now, you take another patient, a 79-year-old who has heart disease and their heart function is extremely low. They've had what we call a cardiomyopathy, and they have a heart failure, and they're diabetic, and they have some renal disease, kidney problems, and now they get diagnosed with breast cancer. Or, I'm just using breast cancer, but lung cancer or anything else, right? And they're going to need some kind of chemotherapy. Now, not all chemotherapy agents can affect the heart. Some of them more than others, some of them really don't. Or, when you look it up, it's kind of like a less than 1% chance that it could affect the heart. Well, everything else in life is less than 1% chance, right? So,
Yeah.
so again, it depends on the cancer, it depends on the chemo. But if someone has a very weak heart muscle, and normally the first line treatment, let's say, is the adriamycin. Well, in those scenarios, we have a conversation with the oncologist, and even the oncologists themselves are not going to want to start that kind of a chemotherapy.
Mhm.
So then the decision will be to use a different kind of a chemotherapy that, might not be first line, it could be kind of second line, but at the same time, giving them that first line agent is going to be too toxic for their body. They simply won't be able to handle it.
Mhm.
And so that's, in those scenarios, we would have to have the conversation about changing potentially their treatment to something that could affect the heart less.
Okay. And so, since this is kind of newer, what can patients do to advocate for themselves about this cardio health piece in relation prior to maybe while they're still in discussion about their treatment?
Yeah,
Yeah.
exactly. And so that's really focusing on the prevention aspect. And
Yeah.
so when patients are being evaluated by their oncologist and there's a plan to start certain kinds of treatments, it's going to depend on what kind of treatment. Again, does the cancer therapy that the oncologist is recommending, have those been implicated to cause any heart damage? How high of an incidence is that? Is it really minor? If it is, well, we're just going to have to accept that risk. But if there is a decent risk, and if the patient themselves already has risk factors, like as we talked about, hypertension, blood cholesterol problems, smoking, family history of heart disease at a young age, diabetic patients, and then they're going to get exposed to those agents, well, they certainly should be evaluated in cardio-oncology to make sure they are as optimized as possible. They're in the best shape possible to go ahead and proceed with proposed chemotherapy agents. And there's also things that we can do. There are some medications that we can add to patients' regimen that can potentially reduce the likelihood for heart damage
Oh,
early on.
okay. It makes me think of your chart about childhood cancers and
Mhm.
how there is a much higher likelihood, even though the numbers are smaller, but for people as they get older,
Yep.
um, to have cardiac issues.
Mhm.
And so I'm thinking for the young people out there who might be listening or people who have children, that have been diagnosed with cancer, do you evaluate them right there? Can they get a referral to come over? Should they be evaluated as in part of their discussion about what that treatment is also? I mean, as
Yeah,
adults, we tend to advocate for ourselves, but as children,
yeah, yeah,
yeah.
yeah. That's a great question. So, almost always with pediatric patients are obviously a very unique patient population, and so the pediatric oncologists do a superb job in monitoring these patients after their treatment. Because we are adult cardiologists, we technically we can only see 16-year-olds and above.
Okay.
So just given the scope of our as being an adult doctor, our medical license only allows us to see 16-year-olds and above, so only adults. Now, and so that's why I think those who were exposed previously, predominantly those who've had radiation exposure, those patients certainly should be evaluated um, down the road. Early on, there's honestly not much we can do. So, in the setting of a young patient who has lymphoma and the best treatment for that, let's say, is radiation or chemotherapy, in that scenario, it's you have to do the best you can do to treat that cancer at the time, and then hope for the best and deal with the side effects and ramifications down the road. And so, if we're able to find those or identify those patients that they survived their cancer and now they're in their, late teens, 20s, 30s, 40s, there are guidelines in terms of how often to image them to try to identify problems early on to potentially intervene again before things become too advanced. And the thing with these conditions, when they do affect the heart, it doesn't happen overnight. It could be over years. So, I've heard this from many patients who had, let's say, radiation when they were they were in their teens and early 20s, and now they're in their 40s and 50s. Well, they're like, well, my growth was always stunted because I got chemotherapy when I was a child, and I've never really been that active and never could keep up with the other kids, and been mostly sedentary, and every time I try to do something I'm more short of breath.
Hmm.
Well, okay, it could be just because you don't exercise, but it could also be a sign of some underlying problem that has been slowly brewing. And so it's not going to be overnight that the patient, oh, today I feel great, tomorrow they're going to feel horrible. This
Right.
must be our problem. This is going to be something that develops over years. And it happens so slowly that most times patients don't even notice it because they just adjust to it,
Yeah.
right? So we
Right.
just end up doing less and less every day over a time period. Then you feel like, oh, I'm not really that bad because I've just been really gradually doing less and less and less.
Right.
So it's really looking for these subtle signs that could be a sign of something early on.
Okay. So that's really good to know for our young cancer survivors, and um, to really pay attention and to tap into how they're feeling as they go through,
Yes.
and to make sure that they start that monitoring early
And
on.
don't ignore symptoms. Don't ignore symptoms, and really just recognize not that they're gonna have this, they're just statistically higher likelihood to develop these complications. Not like every patient who's had radiation or every patient that's had anthracycline exposure is gonna get this.
Yeah.
No, it's just there are higher risk, and there are signs early on that would suggest they're going to develop something like this. And
Okay.
so recognizing that this is a problem, really this is all about awareness, that recognizing this is a problem, to identify it early on, to be able to make a difference.
So it leads me to think that in between, so say you're 24 and you've got lymphoma and you're receiving chemo and radiation, and in between your 30s or 40s and after treatment, would physical activity and change in diet and that kind of heart healthy lifestyle help reduce the risk of a
Yeah.
cardiac, event?
Yeah, that's a great question. We don't have much data on that.
Okay,
Whether we can do things proactively to reduce the likelihood. We don't really have comparison data like that. Hopefully, we will soon. But generally, I would say absolutely stay as active as possible, stay as healthy as possible with dietary choices because it all adds up, right? Because the dietary choices and the exercise that we do early on has an impact on the overall body's health. And
yeah.
anything that we can adapt or adopt to early on is still going to be advantageous long term so
Great.
that you don't develop high blood pressure or cholesterol problems or diabetes, and then it
Right.
puts you at risk for more problems down the road.
So those risk factors that you were counting up on the chart, that you could keep those down, and so then it doesn't put you
Exactly.
in a higher pool. Yeah,
Exactly.
yeah. Oh, that's great. And the only other thing I'm thinking about, question I have is if you're thinking about going into a trial,
Hmm.
and I know here in Grand Rapids we have an excellent center for trials that helps people get connected. Um, would you suggest that they come see you first to look at the regimen of medication? I know that in trials they're careful about that, but I'm just wondering
Yeah.
if in addition they could come see you and
Yeah, I would say it's going to depend honestly on the trial and what that drug is and if
yeah,
it could potentially have any cardiac complications. Sometimes we don't even know if it's going to have any cardiac complications. That's what the trial is for, to start it and then basically sit back and see what happens.
yeah,
So in those scenarios, again, we're more than happy to see patients at any phase, but if it's not something that is typically associated or has been found to have any cardiac problems or very low likelihood for a cardiac problem, it might not be that useful versus some other drug that could potentially have cardiac complications. Yes, absolutely. Would be very worth evaluating patients. Yes.
great. All right. So the only last question I have is if someone wants to come to your clinic, wants to see you, wants to have an evaluation, how do they do that?
Yeah, so I can share the screen again, and I did put this number. It's the 855-7-MY-HEART. And so that is the basically the referral number to get a hold of us into the cardio-oncology clinic. So it's
Great.
855-7-MY-HEART,
7 megahertz.
769-4327.
Great. And I think that we'll post that so that that'll be available for people. And
Great.
do they have to have a referral from their doctor or they can just call directly?
I think part of that is going to depend on insurance because some insurance plans allow patients just to call directly. Some
Yeah.
insurance plans say you must get a referral first from your primary doctor,
Okay.
but we've had patients self-refer too. That's usually dictated by insurance.
Okay. So you guys can help them figure that out when they
Yep,
call.
yep, absolutely. Yeah, if
Oh,
they call and it turns out their insurance needs a referral, then we either contact their primary or we ask the patient, please call your primary to send us a referral. That's something easy we can manage.
oh, great. Okay. Well, excellent. Well, what really just incredibly important information. And we're just so grateful for you giving of your time and your knowledge and being available for our community. What a beautiful part of our community you are.
Oh, thank you very much. Thank you for your kind words. Again, we're available anytime. So certainly, we're happy to help this unique patient population, both myself, Laura Franey, my colleague, as well as Megan Weller, our physician assistant. We're very much, passionate about this really unique patient population and, always available to address any issues that may come up.
Great. Oh, well, thank you so much. And thank you everyone for watching. We're so grateful that you tap in and come with us on this virtual journey to learn new things and stay healthy and stay connected. If you want more information about Gilda's Club and you're on a cancer or a grief journey, you can look us up at www.gildasclubgr.org. We are a free cancer and grief support community. If you have any other questions for the doctor, please just let us know and we'll make sure that they get to them. Or if there's a part of this that you want to see again or have questions about, just email us or call us. We would love to hear from you. It also will be available for you on our website and on our YouTube channel, probably within the next week. It takes us a little while to get the recording up and figured out. So it won't be available today, but soon. So we're looking forward, hopefully, to seeing you either on Zoom or in person sometime when all of this COVID is over. And we encourage everyone to stay healthy, continue to wear your masks, stay socially distant, and stay connected. Thank you again, Dr. Abdullah, for being with us, and thanks to the Cardiac Oncology Clinic. So, all right, everyone, take care. We'll see you soon. Bye.